The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, everybody. Welcome to TMD Demystified. I'm Tony Urbanek. Let's get right to it today. I have a topic that I have touched on before. We're going to take a little different cut at it. Hopefully, I'll make it brief, meaningful, and important for you, the listener, whether you are a dentist trying to solve the problem of TMD, or you are a patient who has the problem and would like a solution. I am going to explain to you why, if you are a patient, why you have been running around in circles about this problem for, it seems like ever, but it hasn't. It's only been since the inception of the diagnosis itself in 1934 by an ENT surgeon who wrote the first paper about the symptoms of TMD. His name was Costin, Dr. James Costin, ENT surgeon, St. Louis, Missouri. I have a copy of his original paper. That was 1934. Since then, the treatment of temporomandibular joint disorder, single disorder, euphemistically called TMJ just about by everybody. Everybody has two TMJs. Has been a conundrum, has been terribly investigated, poorly understood by just about everyone in the dental community because they haven't read the basic science regarding muscles, joints, and nerves. Now, I am a physician and a dentist and have degrees in cell biology and gross anatomy. And it just so happens that I am more inclined to read basic science and actually discovered the cause of all the disparate symptoms, the common denominator, the cause that directly creates each and every one of the disparate symptoms of temporomandibular joint disorder. It's one disorder, and the disorder is the cause, and the cause is chronic inflammation within the temporomandibular joint. Let me repeat that for emphasis, because I really feel sorry for the patients, most sorry for the patients, but my empathy goes out to the doctors, the dentists, who are faced trying to treat these patients, and they do not know what to do because they are not taught the proper amount of information in dental schools. And then once they get out of dental schools, temporomandibular joint disorder has been known quantitatively and qualitatively as the Wild West of dentistry. It's just so. Today's topic is entitled, All the Information Was Available, but dentists didn't bother to read it. And that's just a fact. That may cut somebody deeply, or it may not make any difference to anybody, but it is the truth. All the information about solving this problem of TMD was information to look at. It's been there for decades in the scientific basic science literature, but dentists didn't bother to read it. Even the dentists to this very day who investigate TMD literally, I believe intentionally refuse to look at chronic inflammation and its relationship to causing the symptoms. I could tell you specifics about that, but I think I would embarrass too many people and literally embarrass too many organizations. It's not my point to embarrass people. It is my point to bring out the truth and to make others critically look at the information to find the solution. So all this information has been available. Now, my orthopedic colleagues in the medical profession have done an excellent job, a profoundly superb job of trying to treat surgically and non-surgically the joints in the body to the point where patients can resume function without significant pain. But the dental community, the dental schools have done a terrible job at getting to that point where they can predictably treat TMD, temporomandibular joint disorder, and alleviate the pain and suffering, discomfort, and dysfunction associated with this problem. The most common typical symptoms are, and misdiagnosed all the time by my medical colleagues, frequent and recurring headaches, earaches, diagnosed as ear infections, headaches as migraines, neck pain, jaw pain, tinnitus, ringing in the ears, fullness in the ears, subjective hearing loss, vertigo, dizziness, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Now, those are the well-known, well-accepted symptoms by everyone. There's no discussion, there's no disagreement that those are the collective disparate symptoms. There are a few more that I could go into later on at another time. But today, I want to bring out and emphasize why the solution had not been come up with, and specifically give the reasons, and then discuss briefly and prove where the information can be found, why and how chronic inflammation within the temporomandibular joint creates all those disparate symptoms. Now, as I said, my orthopedic colleagues have done an outstanding job over the years of doing the research and treating joint pain, and they are well aware and have been for decades of a process that they call euphemistically joint splinting. That's what the orthopedic surgeons in the trenches call it, joint splinting. And joint splinting is the explanation of how an inflamed joint then becomes stiff, or the muscles associated with that joint try to hold the joint still so the joint will heal. It's the attempt to splint the joint so that the joint will heal. So there are two answers to why the orthopedic surgeons were able to do it, and the dental doctors, the dental schools, the dental investigators, the dental researchers have not been able to do it. The first is dental schools teach that the temporomandibular joint, TMJ, is unlike every other joint in the body. They teach the TMJ is complicated. It must be complicated because it has a complicated designation, gangliomo-arthrodial joint. That's the classification, the designation for this type of joint. It is a little unusual. It has two purposes, a rotation and a translation. This is translation, this is rotation. But to get the mouth completely open, first you have to rotate, then you have to translate. Therefore, it is classified as a gangliomo-arthrodial joint. But that doesn't make it complicated. That's just a kind of a complicated word for the designation. And they use this complicated word as the justification for why dentists haven't solved the problem. It's a complicated designation. It's a complicated joint. Therefore, we don't know what to do about it because it's complicated. And every dental student is taught this. I can tell you, I have never had this same discussion with a dentist, and he hasn't absolutely agreed with me on this point. They are taught that this joint is complicated, which is not. It's not any more complicated than any other joint in the body. And two, dentists don't read the scientific literature like orthopedic surgeons do. And that is the point of today's topic. And if they did, they would come across the fact that when a joint becomes damaged, It, as I said, sends a signal to tighten up the muscles that move that joint, whether it be knee, hip, elbow, temporomandibular joint. Don't move the joint to allow the joint to heal. But that is not the way the dentists look at it. The dentists, at the very best, want to treat it with symptom relief, with things that are off-label like Botox and paralyzed muscles that have to be reparalyzed every 3 months, or dry needling, which relaxes a joint, but only temporarily, or certainly a plethora of drugs that suppress the basic nervous system to the point that creates significant side effects by suppressing the entire nervous system. Not good treatment. But for your purist, if you are not a dentist, I wanted to, the purist among listeners, I wanted to actually give the definition, the description of this thing that the orthopedic surgeons call joint splinting in detail. I'd like to read it for the dentist to know that this information is out there. It is available. I'm going to give a couple references associated with it if you want to look it up. But the specific definition of joint splinting, according to the literature that has been out there for decades, is as follows. A little more specific, and I apologize to patients who are listening to this because I'm going to go throw out a couple words that you don't quite understand. I'm going to throw you for a minute. The dentist should follow along easily. So here is how joint splinting is described in the scientific literature. Inflammation within a joint activates articular nociceptors and mechanoceptors that alter afferent input to spinal and brainstem reflex circuits. These neural signals modify motor neuron excitability and change the activity of the muscles surrounding the joints, producing protective stabilization or splinting of the inflamed joint. This phenomenon, often described as arthrogenic muscle inhibition, that's the big name, that's the doctor name, arthrogenic muscle inhibition, or reflex muscle guarding, a little more understanding there. I think the patients can understand that a little better. Reflex muscle guarding has been well documented in orthopedic research. Harley, 1997, and Hopkins and Ingersoll, 2000. But they are not the earliest. They are some of the latest investigators who have documented this mechanism that applies to every joint in the body, including the temporomandibular joint. And when you understand this mechanism that has been in the literature for decades, literally 50 years at least, you understand this disease, and you do not have to just treat symptoms. You can treat the cause, and the cause is chronic inflammation, which makes the muscles tight. When the muscles get tight in an attempt to hold the joint still, those muscles pull on the bone, stimulate the nociceptors, pain receptors in the bone, and patients will complain of pain wherever those muscles are attached, whether they be origin of the muscle or insertion of the muscle. And we have muscles first of the jaws and the face and the neck and the shoulders. And that is why patients with TMD complain of various moving pains throughout the upper body, including the muscles that move the jaw, muscles of the neck, muscles of the upper back, and the upper shoulder girdle. And those are the painful symptoms. And then there are the non-painful symptoms, which work through a separate mechanism. That mechanism allows chronic inflammation of the temporomandibular joint to get into the middle ear. Repeat that again. Chronic inflammation inside the joint will get into the middle ear, where the mechanisms for hearing and the vestibular mechanism to keep you upright are affected negatively, and patients complain of tinnitus, ringing in the ears, subjective hearing loss, which is that fullness in the ear, and dizziness, vertigo. And that is it. But all of those symptoms are directly caused by chronic inflammation. So why wouldn't the dental profession attempt to find the easiest and best way to decrease, get away from, do away with chronic inflammation within the joint? They haven't, they don't to this day. They are focused on doing symptom relief with stupid stuff like Botox and drugs and dry needling that are only temporary at best. And no one would disagree with that. Those are only temporary. But if you decrease the inflammation in the joint, you have total control. And the best way to decrease inflammation in the joint, in any joint, is to rest it. That is why, as an example, tennis elbow and TMD are the same disease. If you have a tennis elbow problem with too much repetition motion of the forearm, the inflammation will be in the lateral epicondyle of the elbow, right there. That will become inflamed. And that inflammation will send a signal to the brain announcing it's inflamed. And the brain will send a signal back down through the nervous system that announces, tighten up the muscles that move the elbow, don't move the joint. Hold the joint still so the joint will heal. That is what the orthopedic surgeon colleagues say is joint splitting. And that same phenomenon, which now I've defined twice in two separate paragraphs, creates all of the symptoms regarding TMD. Let me screen share for the benefit of those listening a diagram that I've made available or produced through AI. And this diagrammatically shows exactly what I'm trying to talk about. If I haven't made the point verbally and by waving my hands, hopefully looking at this diagram will help you a little bit better to understand this mechanism, which is central, which is important, which is the linchpin of defining and deciding how best to treat temporomandibular joint disease. So let me get you oriented, make sure this is just a diagram. It's a cartoon diagram, but here is a cutaway of the temporomandibular joint, looking at it with the muscles that move the joint. And here is the TMJ itself within the joint system, which is inflamed due to damage in the joint. It's a very simple process. You have to damage the joint first before you ever get it inflamed. And then if it doesn't heal, you end up with chronic inflammation, and chronic inflammation will send an afferent signal going this way toward the brainstem. And these mechanisms, hopefully the dentist should be at least aware of the nuclei in the brainstem, where most of the unconscious activities within the brain occur. Up here in the cerebrum is most of the conscious activity, but in the brain stem of the brain are the activities that we consider unconscious activities, like gastrointestinal, breathing, heartbeat. The announcement is made to the trigeminal sensory nucleus that there's inflammation. That nucleus gives a signal to the trigeminal motor nucleus, meaning the nucleus that creates the signals to move muscles, goes down to the spinal trigeminal nucleus, which is the motor outlet to the muscles that, in this case, a couple of examples of those muscles would be masseter muscle, temporalis muscle, that move the jaw, that moves the joint, telling them to tighten up, don't move that joint, just like tennis elbow, just like the effect on the knee. The knee is the same thing. And what do you do if you don't want to do surgery on the knee, or you don't want to do surgery on the elbow? And you should never do surgery on the knee or elbow if you can find something simpler to do. Well, the orthopedic surgeons know the simplest way to make inflammation go away on the knee, and that is put patients on crutches. And if patients will stay on crutches indefinitely, then the pain will go away. But you got to stay on your crutches. If you are an orthopedic surgeon and find somebody with tennis elbow, the treatment of choice is not surgery, and it is not drugs, and it is not dry needling, and it's not Botox. It is putting the patient in a sling so that you hold the joint motionless to the point where the inflammation dies down. Now, the conversion into the temporomandibular joint isn't more complicated, but a little more difficult to explain, because what has been worked out, what I worked out, once I understood the cause of the disparate symptoms, the linchpin of the disparate symptoms, the common denominator of the disparate symptoms, is to figure out how to hold the temporomandibular joint as still as possible, take the load off the joint as much as possible to allow the inflammation to go down to the point where the symptoms disappeared. You don't have to treat the symptoms. They will just disappear if you make the chronic inflammation in this joint go away. If you make the chronic inflammation in that joint go away, all the symptoms go away. And the easiest way to do that is to put a device in the mouth that only separates the posterior teeth, because it's the posterior teeth that load the joint. Posterior teeth put 90% of the loads on this joint. So if you unload the posterior teeth according to a protocol, it isn't any old way you want to. You cannot use this device any old way you want to. You have to follow a protocol. The protocol is very simple, 24/7 for 2 months, except when you eat, because you cannot eat with this thing in your mouth. You take it out to eat, you brush your teeth, you put it back in, you do that for 2 months, and then we go to nighttime only, sleep time only, nap time only the rest of your life. Once you get it down, you can keep it down by continually unloading the joint to the point where the chronic inflammation is left decreased or at bay. Unfortunately, you cannot hold the jaw 100% still forever. We have to eat, we have to breathe, we have to talk. And half the population in the country has a habit of bruxism, chronic clenching and grinding, which is related to stress. And we have no solution how to get somebody to stop clenching and grinding. Although there are people out there who claim they can, it won't happen. Everyone's stressed to some point or another. Half the population converts that stress into bruxism, and they cannot control it. It is something they have no control over. So you're left with not trying to get somebody to hold the jaw joint absolutely perfectly immobile, because you have to use your jaw every day, constantly. But we have found that protocol associated with a device that doesn't damage anything other than separate the posterior teeth for a short period of time, at first 24/7, then nighttime only the rest of your life, solves the problem. So I've gone through the description, both in terms that both doctors can understand it with technical terms, and as much non-technical information as I can give about this for both patient and dentists. That is what I want to say today. These paragraphs and diagram explain the painful symptoms of TMD. I did not discover this pathophysiologic mechanism. I did not discover anything. I read the literature, applied what I read in the literature to the facts, and the solution appeared. It's just that simple. It was in the scientific literature. I read it there. It is upon this knowledge that this device, which I had to call the Urbanic device because my patients wanted to call it miracle device, save my life device. I couldn't do that. I wouldn't do that. It had to be branded as something. So we call it the Urbanic device. But I did not do anything unusual. Anyone prior to me could have read the literature and connected the dots. That was there. All you had to do was read the literature and connect the dots. It has amazed me that it took 70 years for someone to come along and do that. If you would like to communicate with me, I can be reached at tony@tmjservices.net. If you are a dentist and would like to use this in your practice, it is a patented device and protocol. We can teach you how to do it. That's what we do here in our company. And I have taught many doctors now throughout the United States. We have doctors in 18 states who use that device and protocol just like we do here in Middle Tennessee. If you would like to criticize, I can be reached at the same email address. And if you'd like to join the network of doctors who do this, that is most easily done by logging onto our website at www.urbanic, URBANEK, TMJ.com, urbanictmj.com. I hope this sorts out for some of you out there who have heard me say these things prior. This is not the first time I've discussed these issues, but I wanted to make it as concise, as clear as I possibly can, give some references about this to prove that this has been in the literature for a long, long time. And not enough of my dental colleagues are taking the time to use their critical thinking abilities to look at this problem in the way it should be looked at, and to find out why they need to quit trying to treat symptoms with things that, if they have any benefit at all, are at best very, very, very temporary. Until next time, which will be next Tuesday when I routinely record this podcast, this episode, I invite you to come back and learn a little bit more about this problem, which used to be considered very complicated and a big conundrum, which I hope, and in my purpose, to simplify it and to bring it to as many doctors and patients as possible. I am Tony Urbanic, and this is TMD Demystified.